So today we talk about joints. So there are many different subjects we have covered. Like within 2 weeks, this is the end, well, not even end, this is the mid-second week. So we studied about introduction to anatomy, we studied about cell and tissue, skin, bones, and now we are going to study joints. So 5 lectures already, including this. And yeah, there's a little, something to grasp other than anatomy from this class. So push yourself hard, think yourself high. You are good. Like comparing to many other people, you are good. At least you are trying to sit in a classroom studying something which you have never learned. So you have your future. So what do you think you become? What do you feel you attract? What do you imagine you create? So that's came from Gautama Buddha. So don't let yourself down. Just keep yourself tight. Push yourself hard. Yeah, you have your future. So, but this is a lecture about joints. So as I say, everything we say, we need to know. Like a bone. If we say, hey, bone, what is a bone? It's a specialized connective tissue, which is made of cell and matrix. We have something to answer. We know the definition. So that if we know the definition, that means we know what we are talking about. So what is a joint? A joint is two parts of the body fitted together. So that is the joint. So site where two parts of the body are fitted together. And what is a ligament? Ligament is a band of fibrous tissue or connective tissue, might be cartilage, might be fibrous, usually a fibrous tissue, ligament. So now the definition, what is a joint? It's a connection between two parts of the body, and ligament is the band of fibrous tissue. Fibrous tissue, what is fibrous tissue? It comes from the connective tissue origin. Connective tissue mean collagen fibers, matrix, and fibrous. So fibroblast, you put fibroblast, you will get fibrous tissue. So bone and joint, you know the definition now. What is a joint? A joint is a connection between two bony parts. So why do we need joints? Let's say if our body do not have any joint, what's going to happen? If our body do not have any joints, then our body will be really rigid, isn't it? It will be so difficult. It will be so difficult. Like, you are like just walking like that. You are not flexible and you cannot move that easily. So the functions of the joint, one of the functions of the joint is number one for the movement, like at least you bend yourself and then feed yourself. So that sort of things, and to support the body as well, to absorb the energy. Let's say if we fell from height, so we try to grasp the energy by just trying to bend our body and then try to absorb the energy, just to support as well. So the function of the joint is to support your body at the same time to give you movement. That's why joints are important. So look at that. How many joints do we have in our body? Loads and loads and loads. That's why a human being is so flexible to cope with our daily routines. Now, look at this skeleton. Hey, skeleton, how many joints do we have? We have elbow joint, we have wrist joint, in between two bones. And if the tissue is here connected together, there will be a joint. So between this is a radius bone, this is the ulnar. Between these two bones, they are wrapped together with the sheet of tissue. That makes a joint. So there is a joint between this long bone radius and ulnar as well. So this joint, our pelvis, this is our vertebra, this is the sacrum, and these are the pelvic bone, ilium. So in between, two bones are connected to each other. So ilium and the sacrum. Sacrum and ilium, sacroiliac joint. So this is a joint as well, whether it moves or not, it doesn't really matter. As long as two bones are tied together, it is a joint. It can move, it might not move. Doesn't really matter as long as two bones stick together and you wrap around with the tissue, which is fibrous tissue, and that is a joint. So, like these are the images from Google. Two bones tied together with the fibrous tissue that we form a joint. It doesn't matter whatever position we try to tie together. Let's say two bones parallel, like radius and ulna, tied together, that is a joint. Crossing each other, tied together, another joint. The same thing, like, end-to-end bones joined together with the fibrous tissue, that is also a joint. So whatever it is, as long as the two bones are joined together with the ligament, it is a joint. And the function of a joint is to support the body and also for the movement of the body. So look at that. This is a picture I got from Quora, like one of the website, they discuss everything. It's quite interesting to read this website. So look at this girl. This is a Mongolian girl. Like she's trying to show off, trying to stand upside down on a, what is that? Might be a crutches. Trying to stand upside down and using her toes and legs to use the bow and arrow. It is amazing. Yeah, it is amazing the way I cannot do that. But what we need to check, hey, look at her joints, her joints are so flexible. At the same time, they are so stable. So both flexibility and stability come together. That is really brilliant. Of course, stability is at the extent of flexibility. If we are too rigid, it won't be flexible. If it is too flexible, it won't be stable. So flexibility and stability goes hand in hand, and there might be a compromise. But these joints, they are strong, they are mobile, and they are stable. Look at that. So on the other hand, this is a clinical condition. Like this little baby is born with a condition called arthrogyposis. Arthro means joints. Arthrogyposis means the joints are immobile. So the joints are so rigid, like this elbow, which is in flexed position, is not going to move. This knee is flexed, it's not going to move. It doesn't matter how far you stretch. You cannot stretch. The way, one of the ways to treat this condition is gradually stretching the limbs. You're not going to achieve much. So that is the best, we can stretch. And look at that. Look at the feet, look at the knee, and look at how can you survive in this environment as a human being with these rigid joints? The good thing is these conditions does not progress. We try to treat it by stretching, but how far are we going to get? God knows. It is so difficult. So this is arthrogryposis. Yeah, so try to remember this name, arthrogryposis. That's a congenital problem. The babies are born with this rigid joint, and it's so difficult life. So what's happened here again? Like this is the knee joint, of X-ray of the knee joint. This is the lower end of the femur, and this is the shadow of the patella, and this is the upper end of the tibia, and this is the upper end of the fibula. Fibula is on the lateral side. This is the X-ray of the left knee. You can see the joint is gone. There is no space at all. Here, there is still some space, but on this medial side, the joint space is gone. And you look at the patella and the femur, there is no more joint space. So this is osteoarthritis. Again, the joint is pretty much worn out, which is going to need a new knee replacement. This joint is gone as well. So yes, there are many problems with the joints. And there are many different things we can use with the joint if we know how to. So classification of joints. So how do we classification joints? So there are many different joints in our body, like elbow joint, shoulder joint, wrist joint, joints. So many different joints. So as a educated person, we have to stand as a like a bird eye side of view. Like we oversee everything. We do not go and dig small little things. We try to stand up and try to oversee everything. Like the muscle, how many muscles do we have? A pectoralis muscle, bicep muscle. No, it's not. The muscle, 3 types of muscle: smooth muscle, striated muscle, cardiac muscle. So that is a very educated way of seeing big, having a bigger picture. The same thing, like, you know, classification of joints. How many joints do we have? Yes, we can classify joints according to the structure. Structure means the way they are constructed, or according to the function. Function means like the way, how they are going to move, how they are going to behave in life. So according to the structure, how they are built, and according to the function, how they are going to work. So there are only 3 joints in our body, 3 types of joint: fibrous, cartilaginous, and synovial. Oh, hey, now the name tells what you are going to see. Fibrous joint means 2 bones joined together with the fibrous tissue. Cartilaginous joint, that means 2 bones joined together, joined with the cartilage tissue. Synovial joint, it's not that usual, isn't it? The name, it's a big daddy. Yeah, so it is a slightly important joint where we need to emphasize a little bit more. But generally speaking, according to the structure, there are only 3 types of joint: synovial joint, fibrous joint, and cartilaginous joint. According to the function, so how they are going to move, it can be synarthrosis. Syn means together, arthrosis means joint. 2 joints are together. So our class, anatomy class, these lectures are, hey, anatomy class is online, but it is not like, it's not 100% online just with the video. It is, there will be synchronous lectures. So synchronous, syn means together, you and me sitting together, synchronous lecture. So synarthrosis means, syn means together, arthrosis means joint. So these 2 joints, the joint doesn't move, or if that moves, just very minimum. So synarthrosis or amphiarthrosis, amphibious, I believe you know the amphibious meaning like water and land. So amphibious, 2-way. So there is some degree of movement with the amphiarthrosis. And diarthrosis. Diarthrosis means it just moves, free movement. So depending on how they move, is it not going to move at all, although the 2 bones are joined together and stitched with the cartilage, fibrous tissue. Therefore, we can say joint, but this joint is not going to move. It is synarthrosis. 2 bones are joined together. There is some degree of movement, amphiarthrosis, and diarthrosis means there is a big movement, big range of movement. That is diarthrosis. So this is a page, a table from our textbook. So there are 3 types of joints: fibrous, cartilaginous, and synovial. So fibrous joint is 2 bones united by fibrous collagenous structure. Cartilaginous joint is 2 bones united by cartilage. And synovial joint is slightly different. We study in detail. And the fibrous joint, there are 3 subtypes: suture, syndesmosis, and kyphosis. Cartilaginous, synchondrosis, and symphysis. And synovial, there are many. So I'm not going to talk a lot about synovial joint because that is something we have to study a little bit more detail. But fibrous joint can be suture fibrous joint, syndesmosis fibrous joint, and kyphosis fibrous joint. So let's go and check what are these. Fibrous joints, so two bones connected by fibrous tissue. There are three types of fibrous joint: suture, syndesmosis, and kyphosis. And their characteristic is there is no joint cavity. So two bones stitched together, and it is really, really tight. So there is no space in between two bones. And it is really, really wrapped with the fibrous tissue. So no more space, no more movement, really tight. So no or minimum movement and no joint cavity. That is the features of fibrous joints. So fibrous joints are suture joints, syndesmosis joint, and kyphosis joint. So sutures are interlocking bones. So I will show you the picture in next diagram. But one bone has got like little digits coming out. The other bone has little digits coming out. They join together and interlock each other. And this interlocking is reinforced with the fibrous tissue. So the bone in our skull, so the cranium, the joint, these are joined by the, like one plate of bone, another plate of bone meet together and join. So these joints are suture joints. So they have some interdigitation between each bone, and they are covered with the fibrous tissue. This fibrous tissue is in continuity with the periosteum, peri, around, osteum, so the outer covering of the skull bone. And these fibrous tissue with age, the fibrous tissue will gradually become ossified, and then there is no more joint at all. Syndesmosis, syn mean together. So two bone wrapped with fibrous tissue. That is the syndesmosis. And kyphosis is a peck in the socket, like our tooth. So the kyphosis is in the bony socket, we push our tooth inside the socket. That is the kyphosis. So these are the three different types of joints in our body. So if we look at that, our skull bones, the whole cranium, the whole skull is made of one sheet of bone, another sheet of bone meet together, another sheet of bone meet together. So these are little interdigitation between each bone, and they will be connected, joined by the fibrous tissue. This fibrous tissue is in continuity with the covering of the skull bone, periosteum, and this fibrous tissue will get ossified when we get old. So that is the suture joint. The best example is the skull. I think the skull is the only part of the body where we have suture joints. There is no other part in the body. And syndesmosis, syn mean together, two bones wrapped together with the fibrous tissue. Thickened fibrous tissue is called ligament, and tibia and fibula. That is the syndesmosis, which is in our ankle. And the kyphosis, this is the jaw, our jaw bone. Jaw bone is here. We have a socket here, and the bone has been packed in the tooth. Our tooth has been pushed into the socket of the mandibular bone. That is, so two bones joined together, that is by definition, it is a joint, and this joint is called kyphosis, which is one of the fibrous joint. Okay. Cartilaginous joint. So two bones together connected by cartilage tissue. Again, their characteristic is pretty similar to the fibrous joint, because two bones are really, really neck tight. There is no more space in between two bones, so no joint cavity. And it is wrapped by the cartilage tissue, so there is no movement or just minimum movement. They are synchondrosis, syn mean together, chondrosis mean cartilage tissue. So cartilage tissue, which is hyaline tissue and the bone together, That is one form of synchondrosis. And symphysis. Sym means together, physis means growing. So two bones joined together with the fibrous tissue, and two bones are covered with the cartilage. So I'm going to show you the picture. So this is the example of the cartilaginous joint. So as we know, this is our humerus, long bone, and we know that we have a growth plate. We have a growth plate, which is what we call physis or epiphyseal plate or physis. So as you can see, this physis and the bone is connected to each other. So two structures connected to each other, that is a joint. But of course, this joint, this physis and the bone joint is not going to move. And it is stitched to each other with the cartilage tissue. So this is one form of synchondrosis. And another example is our first rib, which come and attach to our chest bone, which is the sternoclavicular joint, which is also a synchondrosis. Symphysis, I believe we all know pubic symphysis. Pubic means pubic bone, symphysis means two together. So this right pubic bone and left pubic bone, these bones are covered with the cartilage, and these two bones are joined with the very dense fibrous tissue. So this is pubic symphysis. And this is the vertebral body, one vertebral body, another vertebral body. So two vertebral bodies are joined by ligaments. So that's another joint, which is also a cartilaginous joint, which is also symphysis joint. So synovial joint. So we haven't talked much about synovial joint. We have talked about fibrous joint. We have talked about the cartilaginous joint. And now we talk about synovial joint. Synovial joint is a must know. Once you have finished your anatomy class, you are expected to know everything about the synovial joint. Why? Because many synovial joints in our body. So, and if like rheumatoid arthritis, many disease process like rheumatoid arthritis, what do you call that? SLE, systemic lupus erythematosus. These, all the immunological disorders and joint problem, they are getting into the synovial joint. So synovial joints are really important. And nearly every movable, mobile, useful joints are also synovial joints. So it is a really important joint. So what are the characteristics of synovial joint? So their bone ends are covered with the articular cartilage. So the bone ends are covered with the cartilage, which is called articular joint cartilage, and it is made of hyaline cartilage. So that's number one. Number two, the joint has the capsule, meaning like it is contained in a particular structure. It has a capsule. And there is a cavity inside the joint. So cavity is not very big, but it is just a potential space, but there is a cavity. So for like cartilaginous joint or fibrous joint, two bones are really knit together, and there is no more space, no more joint cavity. So synovial joint has joint cavity, and inside the cavity, there is a small amount of fluid, joint fluid. That fluid is called synovial fluid. So it's just like a little lubricant floating here and there, very thin, flimsy layer. And the joint is, to make it strong and stable, we will use lots of ligaments, which could be inside the joint capsule, intracapsular, or outside the joint capsule, extracapsular, or just within the capsule, capsular ligament. So we are going to use many different ligaments to keep the synovial joint stable. And more importantly, the joint has very rich blood flow, very rich nerve supply. So why do we need this rich nerve supply? Because if you stretch in the joint, let's say if I stretch my wrist joint, I need to know how far I'm stretching. Otherwise, we can stretch as much as we like and we just dislocate the joint. So we can't let it happen. Therefore, then we need nerve fibers, sensory fibers to get the sensation from the joint. And it is also richly supplied with the blood vessels. The blood vessels are important to prevent infection and to secrete joint fluid as well. So guys, I mean, it is a little bit, too much to push, but now we know classification of joint according to their structure or how they are made of, according to their function. Fibrous joint, cartilaginous joint, and synovial joint, according to the way they move, function, synarthrosis, amphiarthrosis, diarthrosis. And this is the very summary of what I have talked about for last 20-30 minutes. Fibrous joint, cartilaginous joint, synovial joint. Fibrous joint, two bones together bind with the fibrous tissue. Cartilaginous joint, two bones together, bind with the cartilage tissue. Synovial joint has its own characteristics. Types suture, I believe you know what a suture means. Like only in the skull, cranium. The suture joint characteristics, the bones are interdigitating into each other. This interdigitation is reinforced by the fibrous tissue. This fibrous tissue is in continuity with the covering of the bone, which is periosteum. Once we get old, this fibrous tissue will get ossified. Example is the bone and the joint of the cranium. Syndesmosis is two bone joined with the fibrous tissue, and gonphosis, like socket of bone, tooth is packed into the socket of bone, mandible bone. That is the joint, gonphosis. And cartilaginous joint, easy to remember, two bone joined together with the cartilage tissue. No joint cavity, no movement or just minimum movement. Synchondrosis and symphysis. Synchondrosis, syn together, chondrosis with the cartilage tissue. Synchondrosis means the bone and the cartilage together, which is the physis or the sternoclavicular joint. Symphysis, this is the easy way to remember symphysis, our pubic symphysis. Right pubic bone, left pubic bone, the bones are covered with the cartilage, tied together with the fibrous tissue. And the vertebral bones here, there, they are joined together. That is also another type of symphysis. And the synovial joints, I want you to remember the characteristics of the synovial joint. The joint surface are covered with the hyaline cartilage. The joint has a capsule, which makes a joint a cavity. Inside the cavity, there is a small amount of synovial fluid. It is reinforced with the many different types of ligaments. It has rich blood supply. It has rich nerve supply. So synovial fluid. So if we stick a needle in a slightly swollen knee and we take the fluid out, knee joint fluid, that is what we are going to get, synovial fluid. So what is a synovial fluid? Synovial fluid is just like, it is ultrafiltrate from our blood. So blood, plasma, which the blood vessel, which is going to the synovial membrane, this synovial membrane will seep out some fluid into the joint. and that is this ultrafiltrate is called synovial fluid. And it also gets some, fibroblasts from the synovial membrane, secrete glycoprotein as well. So ultrafiltrate of blood with some glycoprotein in it. And it is just floating inside the joint cavity. Sometimes it can go into the joint cavity as well as it can come out of the joint cavity. So the articular cartilage will take the synovial fluid into the cartilage, and sometimes, if necessary, it just seeps out the cartilage into the surrounding as well. So that is what we call weeping lubrication. So I will explain that in a later. So synovial fluid, it is the ultrafiltrate of the plasma. It lubricates and nourishes the cartilage. So as we can, this little fluid is just running around like a thin film over our cartilages. And if we stand on the joint, the fluid may come out from the articular cartilage, and it's just make it smooth and make it cushy for the joint. That's the way, we can use our joints for as much as for the lifetime. There are many joints in our body which will stay with us without any problem if we look after them. So this is the normal nature, which is just trying to suit the joint together, synovial fluid, so which is just the ultrafiltrate from the plasma. It lubricates and nourishes the cartilage. In a healthy adult person, so someone like you and me, if we do not have any knee injury or knee problem, the amount of fluid is just about 5 ml. It's just very small, tiny amount. Therefore, this fluid is just like a little thin flame which is covering the joint surface. It is not like a packet of fluid. So once we can see the fluid in somebody's knee, it is no longer normal knee. There must be some pathological process going on with that knee. So let's say if we look at our knees, each other, like about 30 students in this class, and look at the knee needs to, then there should be no swelling at all in our knees because our knees are healthy. But let's say for those, who has damaged the knee, that's slightly swollen. So once you see the slight swelling, there is something pathological process going on. And as we say, it is an ultrafiltrate of plasma. The fibroblasts will be secreting the glycoprotein into it. On top of that, there is hyaluronin, lubricant, protease, collagenase, prostaglandin, everything, quite a lot. So that's why knee joint fluids is pretty unique, I have to say. And the one more property is it is a non-Newtonian fluid. So what is Newtonian fluid? So Newtonian fluid and non-Newtonian. So Newtonian fluid being the viscosity does not change with the flow. This is non-Newtonian fluid. So its viscosity change with the flow. So has anybody in this class, have you painted yourself? Have you done painting and decorating for yourself at home? I believe you might have, I have done it. But I believe, everyone has brushed their teeth every morning. So what I'm trying to say is, if you take the toothpaste is like a little solid structure on your toothbrush. But once you start brushing on your teeth, then it is no longer a solid structure. It becomes like a foamy and liquidy structure. So because your flow change, the viscosity of the toothpaste change as well. So the same thing, like if you paint your house, you just take some paint from the bucket, put on the wall, and then you paint it. But when the paint is inside the bucket, it is pretty thick and heavy. But once you apply it on the wall and you brush up and down, the paint gradually became less viscous, less viscosity. So that is the characteristic of non-Newtonian fluid. Newtonian fluid is like water. So if you stir a bucket of water, it doesn't matter whether you stir slowly or you stir rapidly, quickly, the viscosity of the water doesn't change. So because water is Newtonian fluid and the synovial fluid is non-Newtonian fluids, which means like if you move the joint very quick, the viscosity of the synovial joint will gradually less and less. If you are just moving slowly, there will be high viscosity in the synovial joint. If you are moving quick, the viscosity of the synovial fluid will go down. So that is the feature of non-Newtonian fluid. So synovial joint, it is an ultrafiltrate from plasma combined with the hyaluronin, lubricant, protease, collagenase, protectin, all combined together. That is a synovial joint. Hey, it is so precious. Therefore, we can only give about 5 ml in each knee joint. Yeah. So that is a synovial joint. So this is knee joint, which is a form of synovial joint. This is the lower end of the femur. This is the upper end of the tibia. And that's the bone in front of the femur is patella. And this is the patellar ligament. So coming from the patella, coming into the anterior surface of the tibia. And this is the quadricep tendon. It's going from the patella to the quadricep muscle. And the ligaments here and there, extracapsular ligaments, articular capsule, joint capsule, and look at that blood vessels. There are many blood vessels coming close to the joint from multi-directional, lots and lots of different directions of the blood. So why? Because if there is any problem with the one vessel because of our movement, and if that kink, there is another muscle will supply. So not to worry too much. You can move the joint as much as it moves, and there will be, if there is no disruption of the blood supply, there will be another blood vessel will come and feed that particular point. So yes, this is the these are the blood vessels. At the same time, with the blood vessel, you will see many different nerves. So look at that. This is a typical diagram of a synovial joint. So two bones, one bone here and another bone here. They are joined together, and the bone articulating surface, so the bone joining surfaces are covered with the blue layer of articular cartilage. Blue layer of articular cartilage, which is made of hyaline cartilage. Yeah. So two bone ends, the bone ends are covered with the hyaline cartilage. They are reinforced by the what do you call that, articular capsule here, the big articular capsule here. Ligament. So there will be ligament here inside. Where is ligament? Is not in this. Oh yeah, here, ligament here, big ligament from outside. So that must be extra articular ligament. And this is the, where is it? This is the synovial membrane. So synovial membrane, which is the inner lining of the joint capsule, is synovial membrane, which is going to make synovial fluid. And outer layer of the joint capsule, which is made of fibrous tissue here, fibrous tissue, combination of fibrous tissue and synovial membrane, which will make it articular capsule. And this ligament is is outside of the capsule, so that will be extra articular ligament. We haven't seen the intra-articular ligament yet. So like that is really typical feature of the synovial joint. For example, they have given the example with the shoulder joint. So this is the, what is this bone? Head of the humerus, isn't it? And what is this bone? The glenoid portion of the scapula. Hey, there is a little space, potential space. There is a joint space. The bone here, surface is covered with the, what is this? Oh, I cannot see. Hyaline cartilage, yeah, hyaline cartilage. And articular capsule here, just going here, connecting each other. There will be inner lining of the articular capsule is synovial membrane. So look at that. Where is the synovial membrane? So it is colored with green, isn't it? So synovial membrane covers the every part of the joint cavity inside, except where the hyaline cartilage covers. So the part of the joint inner surface will be covered with the hyaline cartilage. If the hyaline cartilage does not cover, we will have the synovial membrane, which is the inner layer of the articular capsule. And articular disc, in some synovial joints, there are something like articular disc, you know, like the meniscus we saw with our previous lecture. It can be called as articular disc as well. So in the knee joint, we generally, not every joint has articular disc. So it is not the typical feature of the synovial joint. It is just some synovial joint which we have articular disc, like temporomandibular joint, so the joint from our mandible and the temporal bone, sternoclavicular joint, and the knee joint. It improved the articular congruency, so the joint became more conforming and trying to accept each other. So yeah, sorry guys, I'm going to push a little bit more, like another 5-10 minutes, and I will give you a break because too many information. And the bursa, what is a bursa? What is a tendon sheath? A bursa, B-U-R-S-A, bursa is a little pus, you know, like a little wallet, little containing, little bag. So what is a bursa? A bursa is a fluid-filled sac. Little sac of fluid, which is enclosed by the fibrous tissue. That is bursa. So I believe you all must have had bursitis, like especially your if you know any old people at home, like your grandparents or your somebody you know who is in their 50s, 60s, 70s, they got bursitis. Itis means inflammation. Bursitis means bursa, inflammation. So bursa is a little fluid-filled sac. So little sac of space which is filled with fluid. So, and this is made, the sac is made of the fibrous tissue, and inner side of the bursa is lined with the synovial membrane. So this synovial membrane will secrete some fluid, and it become a little cushy structure. So that little cushy structure is going to stay in between bony prominence where the tendons run over it. So it reduces the friction, ease the impact. So that is a bursa, and tendon sheath is elongation of bursa. That is which just follow the tendons. So now in later lectures, you know, we are going to study about the tendons. So the tendons coming from here to there, bicep tendon. So these bicep tendons, they cannot run on its own. If they run on its own, they will just attrition and they will rupture. So we have to put these tendons and cushion with the bursa. Oh, just 1 minute, please. Hello? I'm really sorry. My dad, he's going to be transferred to another hospital. That's why they are calling me. So yes, bursa and tendon sheath. So bursa is a little fluid-filled sac. So that's the definition of bursa. This sac is made of fibrous tissue. Inside, it is lined with the synovial membrane. Synovial membrane will secrete some fluid, which is synovial fluid. And because there's a fibrous tissue outside, water inside, so it is a little bit bouncy, and it gives us cushion. So that is the bursa and the tendon sheath. So look at that in our shoulder joint, what is this bony process called? Acromion, isn't it? Acromion. And this is the glenoid. Both glenoid and acromion come from the scapula. And look at the long head of bicep tendon. It has to run over the shoulder bone. So if we just leave it like that without bursa, it will just like attrition, like it's just rip and then it rupture. So these bicep tendons will last in our body for about 50, 60, 70s. So yes, because it is well engineered, very good engineering. So it just gives us a cushion. So with time, of course, the more we use, we damage our bursa inflammation, bursa will rupture, no more bursa, and then the bicep tendon we get damaged. So look at that, something like bursa, which is running along with the tendon, that is what we call tendon sheath. So yes, this is the tendon running on top of a bony prominence, and there need to be a cushion. That cushion is called bursa. So just one more slide before I let you go. Look at that. This is the MRI scan. Yeah, MRI scan of which joint? I'm listening. Can somebody tell me, please?
That's a shoulder.
Yeah, brilliant. That's shoulder. How can we say that? Because this is the head of the humerus, and this is something like a glenoid, isn't it? Like a little saucer, and like a little saucer, and the ball is sitting on a saucer. It is a shoulder joint. Yeah, so a shoulder joint. So we can see the glenoid. This is the axial section or transverse section. So we are cutting the body, left shoulder being cut like a perpendicular to the body, axial section or transverse section. This is what we see. And this is the right shoulder, which is in coronal section, so anterior to posterior section. So we can see from anterior to back. This is the glenoid, this is the humerus head, and this is the end of the clavicle. And there must be somewhere here which we cannot see, the end of might be here, the end of the acromioclavicular joint. And there is a joint cavity here, and this is pretty similar to the opposite one, the axial section, glenoid here. And you can see some fluid here. It is really white. In this MRI scan, the white T2 white fluid is white because the white water has a lot of hydrogen ions. The MRI scan, the way it works is try to pick up the hydrogen ion from that particular tissue. So if there is a lot of water, there will be a lot of whiteness, and this is really white. So there must be good amount of synovial fluid in this shoulder joint. So which means, hey, this shoulder joint is not quite right. Actually, we only have less than 5 ml of synovial fluid. And this shoulder, there must be a problem with this shoulder. Yeah, so on this MRI scan, there is nothing at all, just very flimsy amount of fluid, which is running over the joint surface. And here you can see a little bucket of fluid, and there must be a problem with this shoulder. So that's the way you can, starting just very basic, you cannot see a fracture, that's why, but at least Is there any problem, major problem, gross problem?
Professor,
Yes, sir.
a quick question.
Yep.
What is it like? Maybe, I don't know if this shows, but like when someone has a rotator cuff injury or something, like would it show like in one of these scans?
Yeah. So this, like, if we want to look at the rotator cuff, this section is very useful, like coronal section. So you can see this dark gray structure. Yeah. This dark gray structure. What it could be? It is one of the rotator cuff muscle. Yeah. So the bone is pretty white here in this MRI scan. The bone is pretty white. Here, the bone is pretty dark. So try to change the signal. MRI scan by using the different signal changes. Yes, MRI scan, the basic principle is it picks up the water, hydrogen ion, and it manipulates this information. So you can make the bone white or you can make the bone dark. So in this, the bone is white. And now the muscle has more fluid than the bone. So the muscle is dark now. The muscle is dark, the bone is white now. So look at this triangular structure, big, dark, gray sheet. That is the muscle. Muscles around the shoulder is rotator cuff. This rotator cuff muscle, big muscle, look at that, really, really big. It is the same size of your humerus head. Then gradually become slim and thin and become a little dot structure. Like it is like something like that. This is the big muscle and become only one structure, which is rotator cuff tendons running underneath the acromion, cross above the humerus head and come and attach. So if there is any problem with the rotator cuff muscle, we will lost the track. Here now we can still see the muscle becoming tendon, and that black structure is keep going here and there. If there is a rotator cuff injury, we will start seeing problem with this tendon area. And gradually this tendon completely ruptured. There is no more tendon running above the humerus. And your humerus will migrate upwards because this muscle is protecting in between. Now, once we lost this rotator cuff, the humerus will migrate proximally. That is one feature of rotator cuff injury, proximal migration of the humerus head. So this is the rotator cuff, yeah?
Got it. Thank you, Professor. Yeah, so there's gonna be like a little bit more space in between there or something.
True. So there need to be a space between the humeral head and the acromion. So if, let's say, if we have somebody who has got like old grandparents, and if they do X-ray for the shoulder, I think just have a look. The space between the humerus head and the acromion is gradually smaller and smaller, which means the rotator cuff is gradually fading away. Like, let's say when we are young, the rotator cuff is this thick, and in the mid-age, like it is half gone. When we get really old, all the rotator cuff muscle gone.
Oh, okay. So pretty much, what can damage it? Is it exercise or like?
Yes, exercise
or age?
Yeah, both. Like with age, because the older we get, the more we have used this rotator cuff more and more, isn't it? So with the use, everything has wear and tear, and because as you can see, this rotator cuff muscle, like if we move the shoulder up and down, which means this rotator cuff muscle is contracting and extending, contracting and extending. On top of this, it has been crushed in between the head of the humerus and the acromion. So yes, that we have bursa. Like finally, when we get to 50, 60, the bursas get inflamed, bursitis. That is not good for the shoulder, the rotator cuff muscle either. Or even when you're young, like baseball player, like you throw the ball, pitchers, like you are using quite a lot of force on this shoulder joint with your rotator cuff muscle, they tend to get lots and lots of problem with the rotator cuff. Like for example, like, you know, like somebody who plays football, like soccer, like you will see they have lots of knee injuries. That's the way, you know, like I posted one video on the canvas, like Michael Owen, who was a very famous English footballer. The way he twists his knee and he damaged his ACL injury. So like in America, the baseball is really popular. And if you are throwing the ball with the really big force, you are using quite a lot of your rotator cuff. And you know, the way you twist the shoulder, it is like squashing this rotator cuff, and they tend to get lots of rotator cuff problem as well. So
Yeah,
look after it, it will last for many years. No, there is no tissue in this wall which is as good as our own body tissue. Right, I will give you, hey, it is 11:05. So let's take a break about 10 minutes. We meet 11:15, yeah? Go away, have a fresh air, and please do come back.
I have a quick question.
Yep,
Of these three images, you said the first one is an axial view,
axial view
or what else was it called?
or transverse view,
Okay. And then the second one is coronal.
corona view. So you are
the
sliding
third
the
one
bodies to front to back. You are looking from the
Right.
front. And this one
Right.
is, what is this view?
That was my question.
That's again like the same like this one, isn't it? This is the left shoulder and this is the right shoulder.
Okay, so that's axial transverse.
That's axial view or transverse view. Yeah, very good.
Okay.
Yeah. So I think, you know, for your exam, you are going to get these pictures. I'm not asking you, oh, what is the pathology here? I'm just asking, what is this view?
Yeah.
Yeah.
And then which one? Okay, so and then the first one, that's a normal joint space.
This one
And
has,
the second one, is that narrow?
the second is, I think, a little bit, you know, if you look at that, this here, this humerus head, it needs to come and join with the joint articulation. So there is some degree of proximal migration, and the joint is a little bit narrow as well.
Okay.
And
then
I
the
think
third one, that looks normal.
that is like, we have a lot of fluid here.
Uh-huh.
So here, the fluid is white here, and it is comparing to this one, there is not much fluid, isn't it? But here, it's quite a bit.
Right.
Usually, we only have less than 5 ml, so not such a thing like being a lot of fluid pooled like a little sac. So that means extra fluid means, hey, there is something going on. We don't know what it is, but we have to, like when you walk in radiology, you know, if you go to radiology, then that is, you need to pick up, hey, there is more fluid than usual. What is going on here?
Okay. All right, thank you.
Okay. We meet 11:15, yeah, 11:15. conference ကို conference ကိုရှင်းတဲ့ဘက်အင်ပါနေထားလိုက်တယ်ဘုံရောဟုတ်ကဲ့ဘုံရောtext ပို့လိုက်စာပေပြီးတော့text ခုလေးတွေမှာပို့လိုက်ရတာပေါ့နော်အဲ့ဒါတိုင်းပြောတာရှင်းတဲ့ဘက်အင်ပါလဲတင်လဲလို့ပြန်ပြပါကောင်းပါတယ်ကောင်းစီမြင်တော့လည်းကိုသွားကြည့်ရအောင်ဒီဟိုအပေါ်နဲ့နောက်ကြဆုံးဖြစ်ပါတော့သွားရင်ကျွန်တော်ရောက်ပြီးတော့အားနိုင်ပြီဆိုတော့ဘုရားကြီးလောက်ရအောင်ပါလားဘုရားကြီးလိုက်တယ်ဘုရားတယ်နေရโอเคเนาะဒါပဲအိမ်မှာဘူးရှိတယ်အိမ်မှာဘူးမရှိဘူးတော့ခဏခဏပေါ်လာတယ်ဟုတ်ကဲ့ဒီအမေကဖျားရှိကိုပရိယာမှာစားလို့ဟုတ်ကဲ့ဒီပေါ်ရေးဒီရအဲ့ဝင်ရဘိုးလာတယ်ဒါတော့ကောင်းနေဒီဘာလို့လဲနေဒီမှာပြောတာဘယ်လိုပြောမှာဒီတော့ဒီပိုင်းရေးဒီကရတော့စက်တင်ဘာယူတော့စက်တင်ဘာနောက်ပိုင်းယူတာဆိုတာအစောစီးပဲယူတယ်ပြောချင်တာလေးဆိုအဲ့လိုသူ့ခါပြရအောင် Okay, so it is. Let's start again. So we are we are not even halfway yet, but we'll cope. So yes, these are the scans, these are the shoulder joints. And so movement of the synovial joint, we say, synovial joint has got good range of movement, or might be pretty free movement. Free means not extensive. Like our elbow joint, it is a synovial joint. It can move very good extent, isn't it? Fully straight, 0 degree, bending to, let's say, this is 90 degree, and this is might be like 130, 140 degree. Of course, it is not 180 degree. It has got good range of movement, but this is like angulation. That's what we say, angulation, isn't it? From fully straight to gradually one angle, another angle, another angle, another angle. So this is angulation. Or sometimes they move on each other's surface. So they glide on each other. Or sometimes like our shoulder, it's just rotation. So there are many different types of movement can a synovial joint do. So we have to know the definition. What is flexion? I'm not sure whether I'm really happy with all these definitions, but this is our textbook, and therefore we have to take it in one way. Flexion means decreasing the angle between two bones. So yeah, these humerus bone and the radius and ulna, increasing the angle means extension, decreasing the angle means flexion. But adduction and abduction, adduction and abduction. Adduction means attack close to the center of the body. Abduction means farther away from the body. So closing means adduction. While splitting apart means abduction. And circumduction means it's just like rotate. That's circumduction. Medial rotation, lateral rotation means this is lateral rotation, and this is getting back to the center is medial rotation. Flexion and extension, increasing the angle, decreasing the angle. So, and these are the sign movement. I believe you can look in the textbook. It is just like flexion, extension, forward flexion, backward flexion, or extension and flexion and extension. So different. So knee flexion, this is the knee flexion. Let's say rotation means twisting around, circumduction, like 360 degree movement. Little special movement like elevation of the mandible means you're getting close back to the center. Depression means just pushing the mandible downwards movement, depression. Protraction means pulling it forward, protraction. And retraction means pulling it backward again, retraction. So these are the little terminologies which anatomy students need to pick up. Is it really important? Yeah, to some extent. But there are many different things which are more important than these. And these are the little terminologies which you will get with time. So don't get too focused on this. It's just like depression, elevation, protraction, retraction. Yeah, you will gradually get this. And for the term like going to each other, that is opposition. And in anatomical opposition, we are supine, supination, and twisting the forearm to different direction, that is the pronation, supination and pronation. That is important. Like forearm, if you are facing the facing your palms forward, that is you are in supination. If you close it, you are in pronation. So supination, pronation, opposition, inversion and eversion. These are just few little things we need to pick up. Dorsiflexion, plantar flexion. So the classification of the synovial joint. How do we classify synovial joint? So according to their movement, like how many axes they move in one plane or in multi-directional or in two-directional. So depending on which plane they are going to move. Let's say our elbow joint, which is it goes only in one plane. We cannot rotate on our elbow. So hinge elbow joint is just the uniaxial. So according to the shape of the joint as well, the way the shape of the synovial joint, it can be plain joint, hinge joint, condylar joint, pivot joint, saddle joint, and ball and socket joint. Ball and socket joint is easy to remember, like our shoulder joint. The MRI scan we saw in our previous slides. So this MRI scan, this is a little saucer here. This is a little saucer here. This is a little saucer here. And this is the ball sitting on top. So this is the ball and socket joint. So shoulder joint is the ball and socket joint. Of course, the socket is very shallow. The socket is very shallow. The ball is pretty big. So that's why shoulder joint is not a very stable joint. So if someone dislocates their joint, it is usually shoulder joint. Yeah, shoulder joint is not a very stable joint, but it is a ball and socket joint. It is multi-directional. You can move your shoulder with very good direction, and therefore shoulder joint is a ball and socket joint, and it is a multi-directional joint. So like elbow joint is only one direction, unidirectional. Let's say hip joint, which is a very deep joint, it is a ball and socket joint as well. So instead of talking too much, let's go and find these synovial joint shapes. So this is the hand. These are the small little bones in our wrist, which we call carpal bones. And the bones here, so this bone from here to the wrist, so this bone, the bones of the hand, not the finger, is metacarpals. So the bone, carpal bone and metacarpal bones. So these carpal bones are like a little blocks of bones. They glide on each other. So they have no direction, like they just move here and there, here and there. So that is a non-axial movement, and they glide on each other. So if we go back to, it is the plain joint, it is non-axial joint. So these are little blocks of bone going over each other, like non-axial. They don't have any direction. They will gently move according to where they are pulled. And this is the intercarpal joints. What about the elbow joint? Yeah, it is like a hinge, like a door hinge. So hinge joint is the unidirectional, only one direction. So our elbow joint is a unidirectional joint. It is a hinge joint. And the upper end of the radius and ulna, they are wrapped together with the ligament, and therefore it is a joint. And this is the uniaxial joint. It's just only one direction. So this is the example of plain joint. As we say, the little bones in our wrist, which are called carpal bones, they have their name, but at the moment we just remember them as carpal bones. And metacarpal bone is the bone of the hand. They are blocks and gliding on each other, gliding non-uniaxial. So hinge joint is the elbow joint. It is just like a door hinge. It's just one direction. And pivot joint, which is just a uniaxial joint. So it is rotating in a pivot, yeah? So it's just pivoting, like twisting, rotating, rotation, vertical axis, and it is rotating around a vertical axis. It is pivot joint, our proximal radial ulnar joint. And these are another example of the saddle joint. Look at that, like a horse saddle. You know, this is the horse, this is the saddle. So it happens in our trapezium. So this is the bone, like you will see in some other bone as well. But at the moment, just try to remember saddle joint and this joint. So shoulder joint is ball and socket joint. So condylar joint, I mean, like a little type of ball and socket, very similar. Like this is the socket, this is the ball, but it is not as typical as the ball and socket joint, and that is, they are called condylar joint. So metacarpophalangeal joint, the bones of our hand, metacarpals, and the bones of our fingers, like phalanges. So this joint is called condylar joint. Saddle joint, hey, look at the saddle joint. Trapezium and first metacarpal, it's just like a horse and the saddle. Horse and the saddle. It's not as typical. Like this is the saddle joint, yeah? Where is the saddle joint? Yeah, so I know, you know, it's quite a lot for you guys to take in one lecture, but we have to sit and think and go back again and then just try to flip the book, try to think again and try to relate. Ball and socket joint, shoulder joint, good example. Hip joint, it is a good example. And so factors influencing the stability of a synovial joint. As I say, for something like shoulder joint is, as we saw on our previous MRI scan, the glenoid is like a little flat saucer. On top of that, the humeral head is like a ball. It is like if you put an egg on the saucer and you walk, it's so difficult to keep it still. The egg can easily drop off the saucer because it is very loose. So the same thing like your shoulder joint is like a little saucer. On top of that, the big ball is sitting because it is unstable, so it can be multi-directional. That is the advantage. But disadvantage is, yes, this little ball can drop off the saucer, dislocate. So what are the structures trying to stabilize a joint? In this, especially the synovial joint. So yes, you know, you have seen or you have had many shoulder dislocation. That is the most unstable joint in our body. If somebody dislocates their joint, it is shoulder joint. So what are the structures stabilizing the joint? So we can classify according to the static factors and dynamic factors. Static factor, the best static factor is articular congruency. So like a hip joint, you know, very deep ball and socket joint, it cannot easily dislocate, come out from the joint. Shoulder joint, its integrity, like its structure is not stable, not inherently stable. Or the labrum. Labrum is the cartilage which covers around the rim. We will see in the later picture. Or the ligaments crossing over the joint. Ligaments crossing over the joint. So these are the structures, static structures. They will be there for you to protect the dislocation. And negative intracapsular fracture, intra-articular fracture. Because intra-articular, the joint has got capsule. It is watertight, airtight. So it has got negative pressure inside. It is trying to absorb, keep the bone together. So if we lost this pressure, then we can dislocate the joint as well. Of course, dynamic factors mean your movement and the way we move outside of the joint. This is the static factors are inherent structures, which is keeping the joint together. And dynamic factors are outside structures, which is like a muscle, like our rotator cuff muscle, which is keeping the joints together, or the tendons running over the joint. These are the structures which are keeping the joint together. So factors influencing the stability of the synovial joint, it could be static factors and it could be dynamic factor. Dynamic factors are ligaments and muscle, which is running outside the joint. And static factors, these are the inherent structure keeping the joints together. So what is this? This is the X-ray showing the left shoulder. And if we look at that carefully, the shoulder joint, the humerus head is no longer on the glenoid. Hey, look at the glenoid. It is a little shallow saucer. The head of the humerus is off the glenoid. So this articular surface between the glenoid and the humeral head is disrupted. That is what we call dislocation. Dislocation means disruption of the joint articular surface. So the glenoid is, the humeral head is off from the glenoid. So the articulation between the glenohumeral articulation is disrupted. This is the dislocation. Yeah, this is the dislocation. So the glenoid and humeral head is off. This is the dislocation of the left shoulder joint. This is the right shoulder joint. You can see lots of ligaments around the shoulder joint because it has got internal structure is not very congruent. So little flat saucer, big ball lying on top. So, and you can see the glenoid labrum. So the saucer is not very deep. So to make it deep, we have the articular capsule and glenoid labrum, making the saucer deeper and deeper. And this is the clavicle, and this is the acromion. Usually clavicle need to be together with the acromion. Now the joint between the acromion and the clavicle disrupted. So this is the disruption of the acromioclavicular joint. This is the dislocation of the acromioclavicular joint. Okay, let's move on to the elbow joint. So this is the sagittal section of the elbow, which means looking at the elbow from the lateral side. And if you do a sagittal section, this is what we are going to see. This is the humerus lower end. And this is the upper end of the ulna, humeral-ulnar articulation. That is what we call the elbow joint. And you can see in front, we have the bicep muscle, which became bicep tendon of the bicep and brachialis. And this is in the back, at the back of our arm, we have the tricep muscle. Tricep muscle became, this is the tricep muscle, which became tricep tendon, came and attached to the ulna. So because the tendons are getting close to the joint and we need a cushion. So we are going to use bursa. So this is the tricep bursa. In front, we might have some bursa as well. And this is the synovial joint. So we will have the synovial joint cavity. Look at that, it is color with the green-yellow color. This is the synovial cavity. And this is the articular cartilage, which covers the joint surface. So this is again a drawing of the typical synovial joint. Of course, if we do not want to look this detail into the joint, we can look from outside. We can see the lower end of the humerus, upper end of the ulna, joined together with the fibrous tissue ligaments. And that is the synovial joint from outside as well. Of course, this is the cadaveric structure. Ligaments from inner aspect, medial aspect of the medial view of the elbow, and these are the lateral view of the arm, lateral view of the outside view of the elbow. So this is the knee joint, again, like big muscles in front of our thigh, which is what we call quadriceps femoris, quadricep muscle of the thigh. Femur, quadricep means forehead. They all come and join together to become the patellar tendon. Patellar tendon, and then come and join the patella and become the patellar ligament, which is running from the patella to the anterior surface of the tibia. So this is the right knee joint muscles, quadricep tendon, patellar tendon come and attach to the anterior surface. And you can see the different ligaments wrapping around the knee joint. So yeah, so it doesn't really matter, don't try to bog down with these different names. But what I want to show you is a structure of a synovial joint, which is really reinforced with multiple ligaments and tendons. If we take out everything, gradually go into the joint, you remember the meniscus, one on the lateral side, lateral meniscus, one on the medial side, medial meniscus, and we get the quadricep tendon, flip the patella down here, and this blue is the cartilage which is covering the joint surface of the femur, and we will have the same covering of the tibia as well. So now we can start seeing the cruciate ligaments. Cruciate means cross. Cruciate means cross. Crossing each other. Anterior, the ligament in front is called anterior cruciate ligament. The ligament behind is called posterior cruciate ligament. So this is the cruciate ligament. This is the lateral view of the knee. We can see the lower end of the femur, upper end of the tibia. We can see the quadricep muscle, quadricep tendon come and swallow the patella and come out as a patellar tendon or patellar ligament. And you can see the crisscross cruciate ligaments. The one from the front is called anterior cruciate. The one from the back is called posterior cruciate. So this cruciate ligament, which is the intra-articular ligament, which gives the stability of the knee as well. So if one cruciate ligament is damaged, the knee becomes a little bit loose, not as stable as normal. So this is the MRI scan, which is the sagittal view, which is the same view. This is looking from the fibular side, lateral side, and this is looking from the tibia side, medial side. And you can see the posterior cruciate ligament here, and you can see the posterior cruciate ligament here, going from back to front. It's a posterior cruciate ligament, and this is going from back to front, it is the posterior cruciate ligament. So if you look at that, this is going from front to back. This is the anterior cruciate ligament. So we need both cruciate ligaments, posterior cruciate ligament and anterior cruciate ligament, so that we can have something like that, crisscross anterior cruciate and posterior cruciate, which is going to help the stability of the knee. So this is anterior cruciate. And let's say if there is a force coming from the lateral side of the knee, so this is the right knee, femur, tibia, fibula, this is the lateral force, and pushing the leg in off away, abduction of the leg, which is what we call valgus. Then we are going to damage and stretch the medial structures of the knee joint. So medial or tibial collateral ligament we got torn, meniscus can get torn, and there could be like compression, like impaction injury on the lateral part of the knee joint as well. So this is the lateral force making the knee joint go into valgus or abduction of the leg. That is a pretty disaster injury. And you see the anterior cruciate ligament is torn here as well. So this is the very intraoperative picture of the knee. This is the right knee. Now we have made a cut. This is the very first step of the knee joint replacement. We are making a cut in front of the knee, open the knee joint up, flip the patella away so that we can see the articular surface of the femur, and this is the articular surface of the tibia. So tibia here, femur here, this is the articular surface, and this is the patella, which is flipped like that. That is the very first step of a knee replacement. Of course, we are going to resurface this lower end of the femur, resurface lower end of the tibia. Temporomandibular joint, you know, so don't get too detailed of the temporomandibular joint, because the textbook said it is one of the, like a particular joint of the synovial joint. So we have all the features of particular joint. On top of that, we also have the articular disc. Not every synovial joint has articular disc, but temporomandibular joint has articular disc. And the wrist bone, let's say lower end of your wrist, which is radius and ulnar. This is your hand bone, which are the metacarpals. And in between the radius and the metacarpal, we have the carpal bones. So carpal bones are like we have 8 small bone carpal bones, which are arranged in 2 rows. So 4 bones, another 4 bones, make it 8 bones arranged in 2 rows, which stay in between the lower end of the wrist and at the base of the metacarpal bone. So these are the carpal bones, which has got their own name. With time, you will need to know the names of these 8 carpal bones. At the moment, don't worry too much about that. And these carpal bones are joined together by the ligaments, which are coming from the radius and ulnar on the side, on the front. So on the posterior surface, on the medial side or on the lateral side, you know, they are all wrapped around to keep all these ligaments together. So this is the coronal section of the hip joint, which is the synovial joint, which is a type of the ball and socket joint. So look at the difference between the hip joint, ball and socket joint, and the shoulder joint, ball and socket joint. It is a very deep synovial joint. So that's why the hip joint, our hip joints are not as mobile as the shoulder joint, because the inherently, its engineering is different, isn't it? It is very deep ball and socket joint. So therefore, it will not be as mobile as the shoulder joint. But on the other hand, it has better stability, comparing to the shoulder joint. So the shoulder joint will dislocate a lot more often comparing to the hip joint. So if we dislocate somebody's hip joint, this is what we are going to see. So in the lab, let's say if we are in the lab with the cadaver, so we will have a specimen which shows the shoulder joint, which is really showing the head of the femur, which is covered with the cartilage. This is the socket portion of the shoulder joint, which is what we call acetabulum, and there is a ligament which is lining the margin of the acetabulum, which is what we call the acetabular labrum. So if we go back to previous picture, the socket portion of the hip joint is called the acetabulum, and the joint margin we have the acetabular labrum. And of course, being a synovial joint, we have the synovial membrane. So all these structures reinforced by the many different extra-articular ligaments, which is if the ligament is coming from the ilium, I would say, and going to the femur, I would say it is a iliofemoral ligament. If the ligament is coming from the pubic bone, from around your pubis, coming from to the femur, pubofemoral ligament. And if the ligament is coming from the ischium bone, which is something you are sitting, ischium is the bone we sit on. So let's say if you are sitting at the moment, you are sitting on this ischium bone. So if the ligament is coming from the ischium going to the femur, we'll give the ligament name ischiofemoral ligament. So iliofemoral ligament, ischiofemoral ligament, and pubofemoral ligament. These are the extra-articular ligament trying to stabilize the hip joint. Thanks God, that is why our hip joint is not dislocating again and again. It is a very stable joint. At the same time, it has got very good range of movement in the hip joint. So these are a few other little ligaments on the medial aspect. We have the lower end of the tibia. This is a heel bone, which is what we call calcaneus. And there is a bone inside, this is called talus. So tibia, talus, and calcaneus, which is forming the hind foot. And navicular bone, again, like you will need to know the name of the bone, not at the moment. So these bones are connected and joined together with these big ligaments. Look at that medial or deltoid ligament, medial ligament. And in between each bone, there are small little ligaments running here and there, here and there. That's why the bone, look at the foot. The foot has many different bones and they are joined together with the small ligaments in between and long ligaments and tendons running on top. So this is the calcaneus, which is our heel bone. This is the lower end of the tibia. We are looking from the lateral aspect, therefore we can see the fibula here. So, and the talus, which is here, and there are many other bones. As we know, in the wrist, we have the carpal bone. In the foot, we have the tarsal bone, T-A-R-S-A-L, tarsal bones. I'm not going to. So it depends on the laxity of the ligament, depends on the laxity of the ligament. The joints can be as mobile as this. This is look at what is he doing? Like going backwards and pulling the thumb and trying to attach to the dorsal surface of the forearm. So that is the joint. It is not the joint which is like many, that is what we call double jointed. So double jointed people, there are like, it is not double jointed. It is just their ligaments being so stretchy. So there will be a few students who has this type of joint. So their ligaments are more lax comparing to the others. So they feel like, oh, they have got, looks like, they have got one more extra joint to do that. Actually, there is no extra joint. It is the ligament which is just stretchy. So look at that. So I believe, some of you guys might be double jointed because it is It is pretty common. It is pretty common. So double jointed means it is not double jointed, it is just a ligament being stretched. Normally, one ligament cannot be stretched more than 6% of its original length. 6% is not much, because let's say if the ligament is about 10 centimeter, then 1% will, 10% will be like 1 millimeter. It is less than 1 millimeter stretch. That is the only stretch we can accept. Otherwise, it will be very painful. I'm a very stiff person. I won't be able to do this. You know, this is very much stretchy ligaments, which is double jointed. The joints are far more mobile. So yeah, the previous slides, they are pretty boring. They have a lot of anatomy. I want you to forget about those slides. So you will be happy with, yeah. So this is a slide I want you to take home. A painful swollen joint. So you are studying anatomy. I believe your next step, or I have followed you guys in the discussion, group discussion. Some of you guys will be going into radiology. Some of you guys will be going into nursing. Some of you guys will be going into medicine. So from today, you might be working in a ER, emergency room, or urgent care, or might be physician, or might be in the radiology room. And this is the knowledge I want to take. I want you to take from today. If you see a person or a patient with the painful swollen joint, I want you to remember this. Yeah, the causes of painful swollen joint. The first thing you need to calm in your mind is trauma, like injury, which is very common. A joint, painful swelling, a trauma, like if you damage the joint will be painful and swollen. So trauma is one of the causes of painful swollen joint. Tumor, especially cancer. Cancer can present with anything. So if you see a patient whose joint is painful and swollen, please do not forget cancer. It is rare for the cancer to present with the painful swollen joint, but it can. And if we miss that, it is a big hit. We can afford that. So trauma, tumor, and of course, infection. Infection is so easy to present. Joint infection, the way it's present is painful swollen joint. So the first step, like if whenever you see a patient with the painful swollen joint, I want you to remember these three: trauma, tumor, infection. Did you damage yourself? Do you have any problem, like any red flag sign which can give like a tumor, cancer, or is it infection? You have has this patient got temperature or something like other infection process going on? So if not, yes, there could be something like inflammatory, like rheumatoid arthritis, psoriatic arthritis, or crystal arthropathy, like gout, pseudo-gout, or degenerative joint, like osteoarthritis, which is very common, or the hematological, like bleeding, hemophilia, bleeding inside the joint. The blood is very irritating in the joint, and the joint will react with the synovial fluid. Then we have painful swollen joint, and the joint capsule will get stretched. It will be painful as well. Or any drugs like apixaban, rivaroxaban, warfarin, like these are the medications which just like thin the blood. With a minor injury, there will be bleeding inside the joint. That will be painful. So I want you to remember this. Whenever you see a patient with the painful swollen joint, this is what you need to have in your mind. Trauma, tumor, infection, exclude that, and the rest could be one of these things. So, and look at that, this joint is red. If the patient is painful and you see the swelling and redness, it could well be infection. So signs of inflammation going on, or it might not be infection, but it might be like a early stage of rheumatoid arthritis or psoriatic arthritis, or it might be gout, or it might be pseudo gout. Then the joint is inflamed, painful, and swollen. So there is more than infection, which can give you a painful swollen joint. So let's say this is the rheumatoid arthritis. This is the metacarp. These are the metacarpals here, and this is the fingers, a phalanx. This is a joint called metacarpophalangeal joint. So this is a picture of typical rheumatoid arthritis patient. So they are metacarpophalangeal joints, which are synovial joint. There is inflammation in the synovial joint. The joints are gone. Integrity of the joint is damaged, and the joint became laterally deviated. So it is now, because of the better and better medication for rheumatoid arthritis, these pictures are gradually less and less, but still exist. So this is the deformity of the metacarpophalangeal joint, which is secondary to rheumatoid arthritis. At early stage of rheumatoid arthritis, the joints are something like that. It is painful, it is a little bit swollen, it is a little bit red. But if we leave that inflammation there, with time, we are going to get this sort of deformity. This is osteoarthritis, which is the knee joint osteoarthritis. So like the bone spiking bones here and there, you can see the bony spike here. There is no more joint space. The bones are grinding on each other, and then this surface is getting white out already, like if you just crushing the bones together. And the one way to treat this is the total joint arthroplasty, so joint replacement. You have to replace the joint, resurface the joint as well. So getting close to the end of the lecture, have a look on this table in your textbook. So which joint, which bone, and which joint. Don't suck yourself into these table too much, these illustration. But at least I want you to go through once or twice on these diagrams. And these little bones, which you will see again, like in our feet, like if we have carpal bones, C-A-R-P-A-L, carpal bones in our wrist, we have tarsal bone, T-A-R-S-A-L bones in our foot. If we have metacarpals in our hand, we will have metatarsals in our feet. Like these are the rays, like first, second, third, fourth, fifth metatarsals. First metatarsal, fifth metatarsal. In between the hind foot, talus and calcaneus, and the metatarsal, we will have the tarsal bones, like navicular bone, cuneiform bone. We'll go into details in the latest lectures. Too much at the moment. We just try to show you and introduce you so that you will start appreciating the bone. And this is the sternoclavicular joint, which is between the sternum and the clavicle, sternoclavicular joint. The joint ligaments trying to attach each other. So these are the bones of our foot. You will have it again, like talus, which is sitting underneath the tibia, calcaneus, which is your heel. These are the metatarsal. So in between these talus and calcaneus and metatarsal, we have the tarsal bone, navicular, cuboid, and cuneiform. Again, don't try to remember this. And that is the end of the lecture. So, joint, what is a joint? A joint is the connection between two bony parts. How do we classify joints? According to their function or how far they move. Like amphiarthrosis, synarthrosis, or synovial, like multidirectional, or depending on their structure, fibrous joint, cartilaginous joint, and the synovial joint. So that is the way so the joint is the connection between two bones. Ligament is just fibrous tissue. How do we classify joint? According to their structure, the way they make fibrous joint, two bone joined by fibrous tissue, that is fibrous joint, two bone joined by the cartilage, that is cartilaginous joint, and synovial, two bone joined by the, it is slightly different. It has its own characteristic. According to the movement of fascian, synarthrosis, amphiarthrosis, and diarthrosis. And I think this might be the best slide of all. You know, it is just a summary of the whole lecture. We talked about 2 hours this morning. Right, has anyone got any question? I believe it is too much for you guys. I know that.
Professor, will this slide be, will this lecture be available on YouTube?
Yeah, I think it is on the canvas now.
Oh, it's already, the recording.
Yeah, the recording, yes. You know, it takes a few minutes to